And sometimes people say, well, I'm addicted to dopamine. You're not addicted to dopamine. You're addicted to the substance or the behavior that causes your unique brain to release a lot of dopamine all at once. It's like a key fitting into a lock. And once your brain has found that key in your lock, you're going to be vulnerable to compulsive overconsumption because your brain will confuse that substance or behavior as necessary for survival.
I'm Dr. Esra Çavuşoğlu, and I've been living a sober life for the past 18 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Soberhead Podcast. Welcome to Soberhead Podcast. This week, we're honored to have Dr. Anna Lembke. She's a Stanford University professor, head of the Addiction and Dual Diagnosis Clinics, and one of the world's leading addiction psychiatrists. You might recognize her from the groundbreaking documentary The Social Dilemma or her best-selling book Dopamine Nation, a fascinating deep dive into why we all crave pleasure, how the brain's reward pathways work, and how to break free from compulsive overconsumption. In this episode, we'll talk about the link between pain and pleasure in the brain, why 12-step program is super helpful to maintain sobriety, and the powerful first step anyone can take if they're worried about a drinking habit, phone addiction, really any kind of addictive behavior. If you're ready to understand addiction on a deeper level and learn how to regain balance in a world filled with tempting distractions, then stick around for our conversation with Dr. Anna Lembke. Our host for this episode is .sub, the space, community, and platform where creatives, experts, and entrepreneurs come together at the meeting point of continents, the Bosphorus. Follow the link in the show notes for more information about events and membership. I'd like to thank Gedik University and Gedik Foundation for their trust in Soberhead Podcast. With their support, it is possible for us to bring you this content at this quality for absolutely free. And of course, every single one who has subscribed to this channel. However, a huge amount of people who watch Soberhead frequently are not subscribed. So, I will ask you for a quick favor. Hit that subscribe button now, because when you subscribe, it helps us make the show better and provides better access to the world-leading experts. Subscribe and share if you like. And I promise to continue to bring you a better Soberhead every day. So, Dr. Anna Lembke, welcome to Soberhead Podcast.
Thank you for inviting me. I'm really excited to be here.
Yeah, I'm so thrilled because even with the name, you can understand that this whole project came out of my sobriety and my willingness to educate people in a way about addiction, especially in my country. I got sober in America and I got trained in America. And 2.5 years ago, I moved back to Turkey with the hope that more people can be influenced by me and by guests like you. So welcome.
Thank you.
Dr. Lembke, you are a professor at Stanford University and you are an addiction psychiatrist and also the head of the Addiction and Dual Diagnosis Centers, correct?
Yes, that is correct.
You wrote multiple wonderful books.
Thank you.
You appeared also on a documentary called Social Dilemma.
Yeah.
But your latest book, The Dopamine Nation, became a landmark and became like a book that people refers at conferences. Actually, it was the first time I heard about it. It was right after the book was out. I was in an addiction conference in Turkey and a doctor referred to the book.
Oh, wow. That's very cool.
That's how I heard about it. But let me first ask you, what made you decide to get into the addiction field?
Yeah, it's a great question. So I went into psychiatry with no plans to focus on addiction. In fact, if anything, I didn't want to have patients with addiction for many different reasons. First of all, I really hadn't learned very much in medical school or residency about addiction. So I didn't have any tools to help them. My own father was a surgeon, was a fairly high functioning alcoholic. He was a binge drinker. So I also had, negative countertransference, which is a term in the field of psychiatry for when we have like conscious or unconscious negative feelings toward patients that have nothing to do with the patient. So for all those reasons, I was like, don't give me the addicted patients. But unfortunately, everybody else in the department was saying the same thing. Nobody wanted to treat those patients. And then at one point, I had a patient who was struggling with addiction. I wasn't really aware until they had a very bad outcome. And then I realized, oh my goodness, I really need to focus on addiction. And I found out when I did that, my patients got so much better than when I was ignoring their addiction. So when I shifted my focus toward patients with addiction, I actually discovered they're an amazing group of individuals. When they get better, they get so much better, and their families get better and their friendships get better. And so, it's been a great honor really in my career to treat this particular disease.
It's interesting, like me and many people that I know, that someone in their family or themselves has a relationship with addiction. Unfortunately, it's not the same in Turkey. There's a different way of understanding the problem than just from a textbook. And you refer a lot to the 12-step program as well. A lot. In many podcasts that I listen to you, so many tools, guidance, message that you use from the 12-step programs.
Oh, yeah. I mean, when I, meet a patient for the first time and they tell me that they've been going to 12 steps or they're willing to go to 12 steps, I just breathe a huge sigh of relief, because those patients tend to get better and stay better longer than patients who don't have that kind of program woven into their lives. I will also add that the 12 steps, like Alcoholics Anonymous and Narcotics Anonymous, are evidence-based treatments. So there's good evidence that shows that when people actively participate in 12-step programs, going to at least 3 meetings a week, getting a sponsor, working the steps, they have outcomes that are as good as people who get professionally mediated care, like go see a psychiatrist or a psychotherapist. And if you follow those folks out to a year, the folks who are doing 12 steps actually have better outcomes than people who go see a psychiatrist or a therapist. Now, you can combine these things, and many people do. They have individual psychotherapy and they go to 12-step meetings. But the whole orientation, the sober social network, the grounding philosophy, the spiritual transformation piece, they're all very helpful for people who engage and participate in that program.
You know that on Soberhead podcast, I do not recommend any product or protocol I did not personally try. One of the best tools I've found is Prolon's 5-day fasting mimicking diet. It's not just another weight loss kit. It's designed to help reboot your body's own renewal processes. I've noticed that after a 5-day FMD, I feel sharper, lighter, and more energized. You can listen to the detailed interview I did with Walter Longo and learn about fasting mimicking diet. So if you want to give Prolon a try and experience it yourself, use Ayık Kafa 15 code to get 15% discount on your initial order. Let's now come to the book, Dopamine Nation. What inspired you to write the book?
Well, Dopamine Nation is really about ideas that I'd been thinking about for probably going on 20 years. The culmination, the moment I decided to write the book was really when I met my patient, Jacob. That's not his real name, but he's given me permission to share his story. He walked into my office and he, in a very shameful way, described his sex addiction and how many things in his life his sex addiction had destroyed, including destroying his own life as he became suicidal in the depths of despair. I realized in that moment that he and I weren't that far apart, that I had developed this addiction to romance novels, which in comparison is trivial, but in my life actually had become, a significant problem of compulsive overconsumption. I started reading romance novels in my early 40s, which is late, but I hadn't really discovered the genre earlier. And then I got a Kindle, which allowed me to get romance novels instantly after finishing one. And I really entered this kind of fantasy world where I was just didn't have to think about my life or my problems. It was numbing. It felt good. And I spent more and more time in that fantasy world to the exclusion of paying attention to my husband or my children, people that I value and that I love. At one point, I was taking romance novels to work and reading in the 10 minutes between patients. So there was this aha moment when I realized, this person who's my patient and his problems with a very serious sex addiction. And my problems with pornography are really emblematic of living in the modern world and the ways in which we've all become more vulnerable to the problem of compulsive overconsumption because we're living in this world that's constantly inviting us, in fact, demanding that we participate in this consumer culture, that we basically narcotize ourselves with everything that's out there, from the food we eat to the games we play to the way that we connect with people to traditional substances like drugs and alcohol. So yeah, that's why I wrote it. I felt like if people understood some of the basic neuroscience of addiction and also some early interventions that they could do, as individuals, as families, as couples, with their therapists, maybe more people would be able to, live better lives. So really, it was about wanting to help people.
Now that you gave a little summary of the book, actually, I read the book. And actually, I was running when I read Jacob's story. And I just stopped running and I had to sit and feel his pain, which I was able to think of what I did and how I felt shameful and how I destroyed people around me. It was a very moving story. You kind of explain where it came, and the name of the book, obviously, it's Dopamine. What is dopamine? Can you explain to the audience who doesn't have the scientific lingo? That would be easier,
Sure.
probably.
Yeah, happy to do that. So dopamine is a substance that we make in our own brains. We make many different chemicals, and it's in the particular class that we call neurotransmitters. So our brains are basically just a bundle of wires. Those wires are the neurons that make the electrical circuits, but the wires don't actually touch end to end. There's a little space between them. That space is called the synapse, and neurotransmitters are the chemicals that bridge that synaptic gap in order to modulate those electrical circuits. Dopamine is one of many neurotransmitters, and it's very important for the experience of pleasure, reward, and motivation. When we do something that our brain recognizes as important to survival, like finding a mate, eating food, finding shelter, then our brain releases dopamine. That feels good, and that tells us at a very basic level to look for more of whatever that thing is. Now, what intoxicants do, or things that are addictive, is essentially mimic the chemicals in our brain to trick our brain into thinking that it's necessary for survival. And also, they release a lot of dopamine all at once. So the more dopamine that is released in response to a substance or a behavior, and the faster that it's released, the more likely that substance or behavior is to be our drug of choice, right? Something that we want to do again, which brings up the important point that we're all wired a little bit differently. So what might release a lot of dopamine in your brain's reward pathway might not release a lot of dopamine in my brain's reward pathway, and vice versa. So for example, I thought that for most of my life, I thought that, I didn't inherit the addiction gene. My dad was an alcoholic, but I don't like alcohol. It doesn't do anything for me except for give me a headache. But the truth is that I just hadn't yet met my drug of choice, which turned out to be the drugification of a version of human connection or love attachment. That's my drug. I mean, when I found romance novels, which kind of distilled that, through the kind of understanding of how novels now are manufactured to be very enticing, to end on a cliffhanger, all of the plot structures of narrative that we've figured out keep our brains engaged. I got very addicted. Yeah, so that's dopamine.
But it's necessary.
It's absolutely necessary.
Survival.
Yeah. And sometimes people say, well, I'm addicted to dopamine. You're not addicted to dopamine. You're addicted to the substance or the behavior that causes your unique brain to release a lot of dopamine all at once. It's like a key fitting into a lock. And once your brain has found that key in your lock, you're going to be vulnerable to compulsive overconsumption because your brain will confuse that substance or behavior as necessary for survival. So dopamine is important. Without it, we couldn't survive. Without it, we wouldn't be motivated to strive, to do the work, to get the reward that we want, and we wouldn't be alive. But on the other hand, in our modern day ecosystem, we've taken all of those natural rewards and we've made them incredibly potent, incredibly available. They're in infinite quantity. They're always in new and novel and interesting forms. And as a result, we're all more vulnerable to addiction.
I heard once, and from a very well-known psychiatrist, addiction psychiatrist, that most addicts, not all addicts, but most addicts are having a low dopamine release biologically. And there are many dopamine receptors. Therefore, when they find their drug of choice, let's say, the brain is now, okay, I'm receiving something that I was missing. So it's kind of a chemical imbalance from birth. Do you agree with that approach?
I mean, there's definitely both animal research and human research to suggest that that might be true. Namely, that people have different degrees of vulnerability to addiction. Some people are much more vulnerable than others. We know that addiction runs in families. We know that identical twins are more likely to have a share of vulnerability to addiction than siblings who aren't twins. You know, if one is addicted, the other would be addicted. And we're always releasing dopamine at a baseline tonic level. And there is a theory that people who are more vulnerable to addiction, that their baseline level of dopamine release in the reward pathway is lower. And so that some of what they're doing is engaging in sensation seeking, even, at baseline, to try to bring those levels up to feel better. This is all consistent with what's been called the self-medication hypothesis, which is about 100 years old. This idea that people who are addicted are trying to treat an underlying psychiatric condition. But in the self-medication hypothesis, the underlying psychiatric condition was always some other condition. It was depression or anxiety or insomnia or attention deficit. And, there's some truth to that too. But I think what's important to acknowledge is that addiction is a disease unto itself. Even if you don't have another co-occurring psychiatric disorder, you can have a vulnerability to addiction that is partially genetically explained and might actually have to do with lower baseline levels of dopamine firing. That's one hypothesis, and there's some evidence to support that.
Well, with this new world, let's say the age of indulgence, of course, now from kids from the age 3, I want to say, because they have their parents' iPhones in their hand, to much older people to whom are interested into some other activities, their constant bombardment with stimulants around us. What do you see? What's happening to this new world? Because it's no longer just cocaine or heroin. It's just like anything and everything.
Yeah, well, I agree with you. I think that is one of the big challenges of modern life, is that we're always stimulating our brains with these supernormal, high-reward types of substances and behaviors. As I hypothesize in Dopamine Nation, I suspect that because we're doing that to our brains are having to compensate by downregulating dopamine production, downregulating dopamine transmission, by involuting postsynaptic dopamine receptors in the reward pathway. That ultimately puts us all in a chronic dopamine deficit state, which is the compensatory reaction to too much dopamine. And a dopamine deficit state looks and feels exactly like clinical depression, looks and feels exactly like clinical anxiety, looks and feels exactly like clinical attention deficit disorder. So we get a lot of folks who come into our clinic and they're not looking for help with, online pornography or online shopping or smoking too much cannabis or drinking too much. I mean, sometimes they are coming in for that, but often they're coming in because they're depressed, they're anxious, they can't sleep, they can't pay attention. And they're also addicted, and they feel like they're using this substance or behavior to self-medicate. What they don't necessarily recognize is that it's the substance or behavior that's causing the psychiatric symptoms. And the way that we explore that is to actually have them abstain from their drug of choice for 4 weeks, which is on average the amount of time it takes to begin to reset those reward pathways. And when we do that, when our patients are able to do that, we find that about 80% of folks, if they can go the full 4 weeks without using their drug of choice, they have improvements in their mood, improvements in their anxiety, they're sleeping better, they're able to concentrate better, like so many parameters are better. And we haven't prescribed any antidepressants, we haven't done any therapy. All we've done is ask them to eliminate their drug of choice. And so that to me is really powerful and really exciting. And it suggests that on a much larger scale, our current mental health crisis is a result of the hyperconsumption of these high reward substances and behaviors. And that if we could just reset our own reward pathways by avoiding some of these quick pleasures and even, engaging in things that are difficult, we would feel better from a psychiatric perspective.
So people come to you and then or to your clinic, and your first suggestion is that them trying by themselves to try to stay away from whatever substance, can be a behavior, can be a chemical, to be able to stay away for 4 weeks.
It depends on the person. So that's not a recommendation that we make to everybody who walks through the door. For example, we would never suggest that somebody who was drinking alcohol to the point where they were at risk for like life-threatening withdrawal seizures or delirious tremens, we would never suggest that they just go home and try to stop because they could die in withdrawal, right? We would recommend a medically managed detox. Same thing for benzodiazepines, often same thing for opioids, which are very difficult to withdraw from. We also wouldn't make that recommendation in somebody who had repeatedly tried to stop on their own and wasn't able to, or who just said to us, there's no way I'm going to be able to stop on my own. For those folks, we recommend a higher level of care. So we have an outpatient ambulatory clinic. People walk in and walk out. They're going to their jobs. They're living in their families. We're talking about the folks who really feel like even kind of continuing on with their life, that they could try 30 days of not using their drug of choice. Those are the folks that we recommend this intervention for.
You also have a wonderful description of this pain-pleasure balance. You shared some research findings that it seems like it's at the same place of the brain, pain and the pleasure system.
Yeah. To me, one of the most interesting findings in neuroscience in the past 75 years or so is that pain and pleasure are co-located in the brain. So the same parts of the brain that process pleasure also process pain. And one of the ways to understand how pain and pleasure relate to each other is to imagine that you have something like a teeter-totter or a seesaw deep in that mesolimbic reward pathway. When we experience pleasure, it tips one way, pain, it tips the other. But there are certain rules governing that balance. And the first and most important rule is that the balance wants to remain level with the ground, such that with any deviation from a level balance, or what neuroscientists call homeostasis, our brains will work very hard to restore a level balance. How our brains do that tells us a lot about what happens in the brain as we become addicted. So for example, when I read a romance novel, that releases dopamine in my brain's reward pathway. It feels very good, and my balance tilts to the side of pleasure. But no sooner has that happened than my brain then has to respond by downregulating dopamine transmission back toward baseline. That process is called neuroadaptation. I like to think about that as these little gremlins hopping on the pain side of the balance to bring it level again. But the gremlins like it on the balance, so they don't get off as soon as it's level, unfortunately. They stay on until it's tilted an equal and opposite amount to the side of pain. That's the come down, the hangover, or even just that moment of craving. When I get to the end of one romance novel chapter, and then I told myself I would stop, but then I really want to read another chapter. So if we wait long enough, typically the craving will pass, the gremlins will hop off the pain side of the balance, and homeostasis will be restored. And that's just how our brain kind of goes back. It's called an opponent process mechanism. What goes up must come down before going back to the level position. Okay, but now if we continue to use our drug of choice over days to weeks to months to years, what happens? Well, basically, those gremlins start to multiply. They get bigger and stronger, and pretty soon they're camped out on the pain side of the balance. So now we're walking around with a balance chronically tilted to the side of pain. That's our chronic dopamine deficit state. And now we've entered addicted brain. Now we need more of our drug in more potent forms, not to get high and feel good, but actually just to level the balance and feel normal. And when we're not using, we're walking around with a balance tilted to the side of pain, experiencing the universal symptoms of withdrawal from any addictive substance or behavior, which are anxiety, irritability, insomnia, depression, and craving.
How long does it take to come back to homeostasis?
Great question. So it's going to be different for every person, depending upon their unique brain and also what drug they've been using and for how long. But what has impressed me in my clinical career is how consistent it is that in those first 10 to 14 days, everybody feels much worse before they feel better. Why? Because when you take the reward off the pleasure side of the balance, those gremlins that have been accumulating on the pain side of the balance will smash us down to the side of pain. And that hurts, and that's about 2 weeks. In my experience, beyond that, things start to get better. By weeks 3 or 4, those gremlins are starting to hop off the pain side of the balance. And for as I said, about 80% of folks that we see by week 4 of abstinence, some people really are sort of back to baseline. Other people, it can take 2 months, 3 months. For some people, it can take a year, 2 years. Some people may actually never be able to return to baseline. They may have lost some of the innate plasticity required to go back to where they were. But for the most part, when people abstain for at least a month, they begin to restore homeostasis. And it manifests clinically as the craving, which feels in that first 2 weeks like it's never, ever going to get better, amazingly starts to dissipate, and people are not constantly consumed with urges to use. They can focus their attention elsewhere. We know that sleep after heavy drinking vastly improves and continues to improve up to 18 months after stopping drinking. Mood, anxiety, all of that, people just report vast improvements. And what's so fascinating is oftentimes they'll be using their drug of choice, again, to self-medicate those things. And in the short term, it feels like it's working because when I first use that, brings me back to homeostasis, and that's a relief because I'm not in pain. But in the long run, that just adds more gremlins to that pain side of the balance.
So now that we started talking about addiction, from my social environment, when I go to places, so many people approach to me like, oh, I think so-and-so is an alcoholic, so-and-so is an addict. And I just try to explain, not everyone who drinks, not everyone who uses are addicts. So I would love to ask you, because you explain it very simplified way to people, that how do you diagnose someone's addiction?
Okay, so there's no brain scan or blood test to diagnose addiction, although it is a brain disease and it's associated with documentable, verifiable, brain changes. But basically, we base it on patterns of behavior from the Diagnostic and Statistical Manual of Mental Disorders, which can briefly be summarized as the 4 C's plus tolerance and withdrawal. So what are the 4 C's? Out of control use, compulsive use, cravings, and continued use despite consequences, or just consequences. You don't have to have all 4 of those to meet criteria for addiction. Usually 2 or more gets you there. So again, out of control use, compulsive use, that is a level of automaticity and a narrowing of our focus on our drug of choice. Craving, intrusive thoughts or images of wanting to use, or long narratives of justifying why we should use, even though we committed not to using. And then the big one is consequences. Continued compulsive use despite harm to self and or others. Other features of addiction include things like tolerance, which we talked about. It's related to the gremlins and to neuroadaptation, needing more of our drug over time to get the same effect, or finding that at the stable current dose, it just simply stops working, or even turns on us and does the opposite, which I've had many patients over the years describe like, wow, cannabis used to put me to sleep and now it makes me anxious. And then finally, withdrawal. That is, when we try to cut back or stop, we have a characteristic withdrawal phenomenon, which, by the way, doesn't need to be physical. A lot of people think, well, I don't get shakes or anything when I stop, so I'm not addicted. But again, the withdrawal symptoms can be psychological, anxiety, irritability, insomnia, depression, craving. Those are all withdrawal symptoms. So that's kind of the formal, diagnostic criteria in a summarized form. Other soft signs to diagnose addiction, I think, are things like lying about it. When people start to have the double life, where over here they're living one life, but over here they've got their secret using life, and never the twain shall meet. So I think that's an important. We used to think that, when people weren't showing up at work or weren't showing up at school, that was a marker of addiction, and that's still true. But more and more we're seeing high functioning people with high functioning addiction, where they're actually doing great at work, or they're performing amazingly at school. And still, in the background, part of their double life, they have a terrible addiction, which is driving them, to be more and more miserable.
How do you convince these people? Because I am approached with a couple of family members, and when they describe exactly, yes, the amount they're using and the way they're using looks like 100% a substance use disorder, but they're high functioning. So it's so difficult to convince these people.
Well, you know, we have to remember there's so much shame and fear when it comes to addiction. There's shame in admitting that there's a problem at all. And there's terrible, terrible fear about stopping, because at some point it just becomes your best friend, your lover, your crutch. And the thought of going through life without it is just horrific. And many people, you know, with addiction have tried on their own to stop and been unable to, or they tried and they stopped for a short period of time and they were absolutely miserable, as we would predict in the short term. So they end up feeling like, well, either I use my drug and I'm miserable, or I stop using and I'm miserable. What we have to convince them is that there's a middle of the road where they can stop using and actually feel really good after some period of time, much better than they've felt in their entire lives. And so I think that's where I really sort of press on the persuasion, is just trying to, first of all, find out what they care about, what they, you know, is it a relationship? Is it their job? Is it some other goal? And then just try to convince them that however it may seem like in the short term, their drug of choice is helping them toward their goal, it's probably not. And if they would be willing to try to stop for a while, they might see, based on, you know, this neuroscience and the pleasure-pain balance, that they're much, much better off, and they feel better if they can stop using. And that's probably something that you can attest to too, right? That I'm guessing that your life, although it took a while, has gotten much, much better since you got out of your addiction.
Oh, definitely. I said I would not change for nothing the life that I live now compared to back when I was using. So I think I'm a good role model to people who are trying to get sober. That's why I out loudly sharing my story with people, so that they have the hope that, you know, okay, you know, their loved ones should not stay in this pain place, and they can pursue the treatment or a better outcome. So, Dr. Lembke, because I'm not an MD, I still couldn't I know and I accept, but couldn't still wrap my mind around how chemical dependency, behavioral dependency can affect the same way the brain. Because in one, you have also the chemicals crossing the blood-brain barrier, besides just releasing dopamine. So what made it all of them come into one place, and we all call it a substance use disorder?
Yeah, great question. So anything that is addictive mimics something that our brain already does, okay? So alcohol works on our endogenous GABA receptors. Those are our inhibitory and calming receptors, and our endogenous opioid receptors. We don't think of alcohol as an opioid, but it works on our opioid receptor system. Cannabis works on our endogenous cannabinoid system. Psychedelics work on our endogenous serotonin system. And all of them, through different chemical cascades, release dopamine in the brain's reward pathway. So dopamine is kind of like a final common currency. Process addictions are basically just the same thing. So we're wired to connect with other humans. That's innate to us. When we make intimate human connections, that releases oxytocin, which is our love hormone, which binds to dopamine-releasing hormones in the nucleus accumbens, our reward pathway, and we get a jolt of dopamine, and that feels good, and that makes us want to stay connected to people and stay in love, right? Process addiction, like a sex addiction or a sex and love addiction, or even a social media addiction, which is, you know, a form of distilling human connection down to its most addictive elements, is really just working on that human connection reward pathway, just like alcohol works on the GABA and opioid pathway. Human connection works probably on the serotonin and the opioid pathway, all leading to dopamine. There's a whole series of experiments in rats, for example, where if you stick a probe in the rat's reward pathway and you measure dopamine firing, and then you expose the rat to different types of rewards, you can see how much it increases dopamine above baseline. You know, chocolate increases dopamine firing in a rat 50% above baseline. Sex is 100% above baseline. Nicotine is 150% above baseline, and on like that. So you can see that chocolate and sex, chocolate's a substance, it's a food, but sex, for example, that works just like a drug, right? It releases dopamine. It feels good. And in some ways, sex addictions are even harder to combat because, as one of my patients said, the bar is in your mind. Like, you don't even have to go get it, right? It's just in the life of, the fantasy life and masturbation. Food addiction is very difficult because, of course, we can't just abstain from food, right? Can't just stop eating. So then it's a matter of abstaining from the types of food that cause a lot of dopamine to be released in our nucleus accumbens. At the top of that list is sugar. And if you've ever tried to stop eating sugar for 30 days, it is hard. First of all, it's very hard to find food now that doesn't have sugar in it. Even bread has sugar in it, most breads. Many cereals, many meats have sugar in them. It's hard to find food that doesn't have sugar in it. And it's really hard to stop eating sugar. So, really, these are all the same. It's the same reward pathway. It's the same natural history. So when we see patients in clinic who are addicted to video games or addicted to social media or addicted to online pornography or online shopping, they look just like the people who come in with alcohol and drug addiction, right? They start out for fun or to solve a problem. If it works, they keep going back to it. Over time, they develop tolerance. Now they need more and more to get the same effect. Pretty soon, they're marshaling all their resources to get their drug, use their drug, hide using, get some more. It takes up their whole life. And then eventually they get to a point where they can't stop even when they want to.
So it's not necessarily the molecules of the alcohol or drugs passing through the blood-brain barrier that is making it happen. It's just through these molecules what's firing in the brain.
Yeah.
What's the single most important action someone can take today if they're suspicious that they're caught in this dopamine-driven state? And I'm not just talking about an addict that you would diagnose, like so many people.
I have this kind of dopamine acronym that starts with D, stands for data. And really, the first step is to gather the data to increase our awareness. Because the truth of the matter is that when we're chasing dopamine, we really can't see true cause and effect. We don't see the impact that the behavior has on our lives. It's like we're blind to it. Other people can see the harm potentially, but we don't see it. So the first thing to do is to just sort of like write down or tell another human being what we're consuming, how much and how often. I often recommend using something called the timeline follow-back method. That is, and we do this in clinical care where we ask patients to go every day of the week, how much they consumed and what they consumed over a full week. So let's say it's something like, social media addiction. Okay, how long were you online yesterday? How about the day before that? How about the day before that? And what comes out is that the person may say, well, I was online about 3 hours every day. 3 hours every day doesn't seem like very much when you're just looking at one day. But when you add up 3 hours over 7 days, you get 21 hours. Wow, that's a lot of time spent consuming social media. So I think that awareness is really key as a starting place. And we can't get that awareness unless we tell somebody else or write down on a piece of paper or somehow put into language and numbers what we're actually doing. So I think that's an important starting place.
Now, when you were giving the method, I was thinking in my head, about, I'm a big chocolate fan, and I'm like, I eat only, let's say, 2 click here and 4 click there. And when I start adding them up, it's like a whole box at the end of the week. And when you think about the box, it's a big thing. So, there's this, after your book especially, the people are talking about this dopamine fasting. So it became very popular.
I mean, we've been doing this in clinical care for decades, right? Which is just basically asking patients to do an experiment and try stopping their drug of choice for 4 weeks or 30 days, knowing that in the first 10 to 14 days, they'll feel worse before they feel better. The craving will feel like it's never, ever going to go away, but they need to trust us. If they can just get to week 3 or 4, the brain will start to reset reward pathways. And that's a dopamine fast, or at least the kind of dopamine fast that we do in clinical care, where we're asking folks to really choose the problematic substance or behavior, not to necessarily quit all pleasures. The quitting all pleasures and like going into a dark cave, that's sort of like the Silicon Valley tech bro dopamine fast, where like they go into a cave, they don't do anything for a week, they come out and they like see a little leaf and they're euphoric because it's like they're seeing green and not in the dark. That's actually the same phenomenon. I mean, it's the same brain phenomenon, but in clinical care, that's not what we're recommending. And like for digital media, people have to go to work, they have to go to school, they can't just, put their phones away, even if they wanted to. So then it's a matter of saying, okay, what apps are you going to delete? Are you going to delete all the pornography apps? Are you going to delete all your online shopping apps? Or maybe get rid of your credit card. Are you going to delete your video games? There are different softwares where you can have other people see what you're doing online. So that's, you can have an accountability buddy to help you stay true to your commitment to not use that substance or that behavior for a month. So that's essentially the dopamine fast. And if people are willing and able to do it, we have them come back a month later and do a kind of pros and cons list. What was good about the dopamine fast? What was bad about the dopamine fast? Almost universally, there are a lot of good things. People say, I slept better. I was more present. I had more time. I got more done. My mood was better. I was less anxious. That's all after they get through the first 14 days, which are hard. On the what was bad about the dopamine fast side, people are like, well, I was really bored, right? I had all this time that I used to use engaging in pursuit of my drug and using my drug and maybe covering up my drug use. And I didn't have that to do, so I didn't really know what to do with myself. And boredom can be a really scary emotion at first, but a great opportunity also for creativity and to examine ourselves. And then the other thing they often say is, I couldn't hang out with my friends, right? Because we tend to affiliate with other people who use our drug of choice the way that we do. And that normalizes it for us. And so they often say, well, I couldn't hang out with my friends because they're using. And that's a real issue, as people think about how they want to use then going forward, because that's when we ask them, do you want to continue to abstain or do you want to go back to using? And most of the time at first, they want to go back to using, even if we don't think it's a good idea, but they want to use less. And so the key there is to come up with an extremely detailed plan of what that's going to look like. What are you going to drink? How often are you going to drink? In what circumstances? Who are you going to drink with? And I'm going back and forth between a drinking and traditional drug and digital media just to emphasize that these are all the same. It's the same phenomenon. And then sometimes people are successful at moderating their use. Often they're not. And they immediately plunge back into their addictive behaviors. But they have to sort of get the data for themselves, right? I can talk till the cows come home about why they should, why you should try not using or, what you should do next. But people, they need the experiential knowledge for themselves.
So we're coming to the end, and I want to ask one last question. What would be one idea or one message you prefer people or you would like people to get after reading your book? Because it's translated in Turkish as well. Yeah. And what would be something that you really would people to pay attention to?
I guess at the end of the day, I want there to be a strong sense of self-compassion and a kind of de-shaming and an acknowledgement that we all strive for pleasure and avoid pain reflexively. We're all vulnerable to the problem of addiction. That this is a very difficult time to be alive in many ways because there are so many things we can get addicted to. And to so have some self-compassion, have some understanding for what's happening in the brain, and then, use that to motivate ourselves to live our best lives.
Thank you so much. That was great. Just meeting you, it's wonderful. And thank you for accepting my invitation. Hopefully one day I'll be able to meet you in person.
Well, thank you. It was great to meet you. Thank you for your work in Turkey for, de-shaming and destigmatizing and helping people get into recovery. It's so important to have role models who give us hope about how we can live our lives differently.
We were able to do that for the last 16 years, actually, in southeast of Turkey. We built a treatment center for youth.
Oh, wow.
Yeah,
that's great.
I'm not sure if you're familiar with Dr. David Powell, who passed a couple of years ago, Mark Fishman, Susan Blank, bunch of American doctors who came over, and we built a residential treatment program, and we have over 1,000 now young adults that are carrying the flag.
That's so cool. Wow,
so
that is really great.
I'm devoted to it.
Yeah, that's awesome. Congratulations.
Thank you so much again for your time.
You're very welcome.